that's up. Oh, you're in the middle. Okay. Thanks for your help.
Thanks so much for the invitation to be here. It's a great opportunity for me to interact with leadership of ABMS and ABIM. We've been having kind of a conversation through internet, but it's really nice to meet you face-to-face and get to talk about this. So I'm going to present the alternative side. I call this boarded to death, why maintenance certification is bad for doctors and patients. Intentionally an argumentative title. So my disclosures, I like CME. I'm a big fan of CME. I participate in CME conferences and I direct a large conference, CME conference every year. I also, several weeks ago, launched a alternative certification organization called the National Board of Physicians and Surgeons, which is in response largely to MOC. So look, I'm going to spend 2 minutes explaining how I got involved in this, because I think it's important for you to understand where I came from. And it goes back to a year ago, February 2014. It was 3 o'clock in the afternoon, and I don't know why, but suddenly I found myself with 40 minutes with nothing to do. That's very rare. I'm usually multitasking. So like a good citizen, I had this MOC thing that started in January, now it's February, I better get going with this. So I logged onto the website to start the new MOC requirements. Now, I direct the cardiovascular division, the system-wide cardiovascular service line, the fellowship program. I'm not a political person. Not doing MOC never even occurred to me. Just the issue was how I was going to find the time and energy to get it done. So I log onto the website, and this is what I see. I'm here on the tab for maintain and renew. And you read it, and you have to click here, click here. You have to click at all these different blue boxes, and each one leads you somewhere else. And it gets very frustrating. Pretty soon I started talking to my computer, because I only had 20 minutes left, my 40 minutes. And I said, what do you want me to do? And my secretary came, what's the matter? I said, just tell me where to click, and I'll click. I can't even figure this out. I was frustrated. Now, I don't know how many of you know Morton Kern. Dr. Kern is the chief of medicine at the Long Beach VA, and he did something amazing with social media that I really recommend you think about doing in your own fields. It started with about 20 docs. A doctor had a patient-related question, not a black and white question. And Mort said, I don't really know how to answer it, but let me send it to some of my colleagues. And now we have about 120 or so recipients. It's an email. It's nothing fancy like Facebook. It's just an email with 120 docs on it. Most of them are thought leaders, a lot of academicians, and it's a wonderful exercise in social media helping. You can ask a question. In this case, Dr. Pelican is asking about coronary aneurysms and continuing pilots. And what you do is about 20 people, so usually answer, and they give you their opinion, and it's like getting consults, 20 consults instantly. So I was frustrated enough that I went and asked the group this question. The subject line was, enough is enough. Is anyone else profoundly annoyed with the new MOC requirements? That's all I said. Well, the response was crazy. It was overwhelming. Instead of 20, we had probably 7 respond. And there was pages and pages of very emotionally negative responses. And these were our thought leaders, and many were academicians. I was surprised by that. About a week of indignant complaining back and forth. And then finally a unanimous question emerged. Paul, what are you going to do about this? So I was basically guilted into this. And so I figured I got to do something. So I found out how to do a petition online. It's actually pretty easy. And I got on this Petition Buzz website, and we created this petition, which now has almost 23,000 signatures, asking the ABIM to recall the MOC. That was fine. So about 6 months of collecting signatures go by, and I started to get emails and comments on the petition asking, okay, what's the update? Has the ABIM done anything? Dr. Teirstein, what are you going to do about this? So finally, after another 5 months and at least 500 hours, probably maybe 1,000 hours of unpaid work, we established an alternative board certification system. So that's where I came from, not political. I started out the whole process saying I do not want the last 10 years of my career to be about MOC. It looks like certainly the last year has been that way, so hopefully it won't be the rest of my career. I want to now focus on the data, because we talked about data earlier, and this gets brought up a lot. Are there really data supporting MOC? And the argument, you heard it this afternoon, that there are data supporting the value of MOC. However, when I closely look at the reports cited by the ABIM and the ABMS, it seems they support the opposite conclusion. Now, I'm not just making this as a sort of a joke, debating tongue-in-cheek reply. I mean it. ABMS's own data support the opposite conclusion. I'll give you some examples. This is a typical example. This is a JAMA commentary, and it's written by Drs. Holmby and Lipner, and they are affiliated with the ABIM. And it's a lot to do with recertification and MOC. And here's the sentence: there is evidence to support the link between board certification and examination and quality. References 16 to 23. So I looked at references 16 to 23. I looked at the papers. So here's the first reference. Sharp. This is typical. You look at the reference, and this is what you find. So this is the paper. And the conclusions: among the screened studies, more than half support an association between board certification status and positive clinical outcomes. Okay? Then you look at the results. Of 33 findings, 16 demonstrated significant positive association between certification status and positive clinical outcomes. 3 revealed worse outcomes, and 14 showed no association. Now, my parents didn't send me to private school. I went to the New York City public school system. But when I add 3 with worse outcomes to 14 with no association, that's 17, which is more than 16. So the conclusion should be that the screening study, less than half, supported an association between board certification status and positive clinical outcomes. I don't really understand how this gets written in the academic medicine journal, but it's written, and it doesn't really, it's not consistent. The authors, by the way, the last 2 authors are vice presidents of the ABIM, and they even agree that the published studies are really not very good. They write few published studies use research methods appropriate for the research question. And by the way, you get all this just from the abstract. You don't even have to go into the paper to see where this is really not a very convincing argument. And this is the argument used by ABIM, ABIMS to justify certification and recertification MOC. It's important if you're looking at this data, I want you to make sure you're looking at initial certification versus maintenance or recertification. Almost all the studies you'll find, and there are a lot of them, there are maybe 70, 80 studies, they usually look at certification. And even that data is kind of equivocal. But think about what initial certification is. Mostly, it's the training program. It's the ACGME credential training program, which is pretty rigorous, and I think pretty good. The ABMS provides a sort of a final test, and that's fine. But the real core of the training, of the knowledge, comes from the training program. Should it be surprising to you that a cardiologist who spends 3 years doing a cardiology fellowship and then takes a secure examination does a better job at treating heart attacks than a doctor who didn't do a cardiology fellowship? I mean, that's, to me, sort of obvious. So that's quite different than MOC, which to me is putting on computer modules for 10 to 20 hours each year and then taking a secure test after 10 years. I think it's really important to distinguish that when you're looking at the data. So is there data on MOC? Well, there are some studies. So this is one from last year at ACC. This is the NCDR database. This is the registry we all contribute to when we're doing PCI. This is one of the few studies examining last certification, and they found no impact on patient outcomes. So here's the data. It's only an abstract. It's not the best. The quality hasn't been published yet, but the data looks at 5 different groups, depending on when they finished their fellowship and whether they ever got certified. But if you look at the lapsed group at the side here, the lapsed group, it's only 309 patients. But the p-values are all non-significant. There's no difference. And in fact, if you look at death over here, the hazard ratio is 0.91. So it's even going in the wrong direction. So it's not even a signal here. So that's one study. Then we received 2 studies in JAMA. You probably saw these a few months ago. And there were sister papers back-to-back, one from the VA, looking at physicians who were grandfathered, who had time unlimited, versus non-grandfathered physicians on ambulatory patient care quality. And what is the conclusion? Among internists providing primary care at 4 VA medical centers, there was no significant differences between the grandfathers and the non-grandfathers. No difference in outcomes. The other paper, a little more controversial. This looked, again, at the grandfathers versus the non-grandfathers. It's very well done, very detailed statistical analysis, and they were looking at ambulatory care, sensitive hospitalization, and healthcare costs. So the data, the outcomes are on the top here, and the p-values are all non-significant between the grandfathers and the non-grandfathers. Over here where my arrow is, that p-value is 0.07, that's for emergency department visits. So that's close to being significant, but there's a problem that's going in the wrong direction again. There's less emergency department visits for the grandfathers. Then you get down to the costs, and the costs were different. All the p-values are significant here, and the cost difference is only $167 per beneficiary, so a very small difference. And that is the conclusions of by the authors were that the MOC requirement was not associated with a difference in ambulatory care sensitive hospitalizations, but was associated with a small reduction in growth differences. Now, I've heard Dr. Barron has made a point of the small differences. It's small, but if you multiply it by the number of patients, it's only a 2% decrease in cost, but we've got some 50 million patients or so being treated every year. That ends up being $2 billion. But that misses the point. The point is that this is not a randomized study. There's a lot of limitations. It's a propensity matching followed by a regression analysis. So beware. You all know how to do this. You have to be aware of all the unmeasured confounders, and you can't take, when it's just a small difference, you really have to be careful if you want to interpret those small differences. So it's really how the study was done, which is the problem. Now, just to give you an example, if you look at the comorbidities, so here on the left you have the MOC required, and then you have the grandfather on the right. Just look at heart disease, diabetes, and vascular disease. It's not significantly different, but they're all trending worse for the grandfathers. And this is after the propensity matching. Okay, so these groups really are not totally the same, and they're making it a little bit harder on the grandfathers. That's just one example. It's a very complex statistical analysis. If you read it, I had to have help from my statisticians. And basically, the statisticians comment it's highly adjusted, it's very well done. A lot of smart statisticians did it. When you have propensity matching followed by regression analysis, it's just a lot of adjustments being made. I think it's worth looking at the authorship of this paper. So these are the authors, and you'll see that if you have a 1 next to your name, you come from the ABIM. And 4 of the 8 authors have a 1 next to their name, and Dr. Hombo has a 4, and he's with ACGME now, but he was with ABIM up until about a year ago. So really 5 of the 8 authors are from the ABIM. And then you look at the author information, and down at the bottom, the role of the funder. The funder was the ABIM, but the ABIM had no role in the design, conduct of the study, collection, management, data analysis, etc. Except if you look at each individual author, the concept of design was by, well, 3 of them are ABIM affiliates. And same thing for data acquisition, and drafting of the manuscript, and critical review. So it's a little confusing because the bottom part doesn't really match the top part. And I'm not really sure, I don't understand that, but bottom line is that many of the authors of this paper were very, very involved with the ABIM. Why is that important? Why should we worry about conflicts of interest, particularly when we're looking at a non-randomized trial? Well, if you look at the paper, where the endpoints were specified, well, it doesn't say that in the paper. So, I mean, maybe this small difference in cost was discovered after looking at multiple endpoints. I don't know. Were there any differences favoring the grandfather cohort that weren't published? And this is the problem when you have a non-randomized study and you have conflicts of interest. And finally, I'll show you my last piece of data. This is really interesting. I received a letter from the New England Journal of Medicine last week. And the letter was in response to the dueling perspectives that we both wrote on the MOC issue. And essentially, they sent me the letters to the editors. They said, we're not going to publish the letters to editors, but we thought you should have them. So most of them were pretty complimentary. And then I found this one, which was written by Dr. Barron. And it's a very polite, very well-written letter. It should have been published. It was certainly well-written enough to be published. And it makes his points. And there was one segment that really drew my attention. He writes, my commentary omits a comprehensive 2013 meta-analysis. It's reference 2. Dr. Lippner's paper. So I thought I did a pretty good job. I worked really hard to make sure that it was a good perspective, and I clearly missed this comprehensive meta-analysis, so I went and looked at it. So here's the meta-analysis. It's from the Journal of Continuing Education and Health Professions. Dr. Lippner and Hess, these are authors who are affiliated with the ABIM, and they write, in general, physicians who are board certified provide better patient care, albeit the results have modest effect sizes and are not unequivocal. So again, I have to go back to my New York City public education on this. Modest effect sizes, I think that means small, and then not unequivocal, I think that means equivocal. So you have to wonder why it's written that way, but I think you find out soon. When you look at the body of the paper, it's really not a meta-analysis. It's a literature review, and what happens is they look at about 30, 40 papers, look at the quality measures, and then one line about the results. So you see the top line for peptic ulcer surgery. If you're certified, they had a lower mortality, and a lot of them showed no difference, and there was a few that showed some difference. But this was not a meta-analysis. This is not a comprehensive meta-analysis. This is from the paper itself. It says there's several limitations. A meta-analysis was not done. And then it's really an equivocal literature review. 24 of the 29 studies listed really look at clinical outcome as certification, not recertification. There were 5 that looked at MOC, but they looked at MOC's test scores, not whether or not you participated in MOC. And it's written by an ABIM affiliate. Now, do we really need more data? We hear that all the time when we have this debate. I keep hearing calls for more data. Now, more data sounds good from the podium, looks good in print. But think about it. What kind of data quality will you really ever be achievable? Level A, randomization. Are we going to randomize physicians to be MOC versus no MOC? Can we blind doctors? Of course not. Unfortunately, the data will always be registry data with massive bias. In my opinion, asking for more data is a cop-out. It just kicks the can down the road. Reminds me of my favorite trial that I sometimes use to make a point, the Holy Shoot trial. This is Group A versus Group B. Now, this is a good trial to do because it's actually a very inexpensive trial. You can use mortality as an endpoint, and I've done some basic power calculations here. And I think about 40 patients, you'll get this because the DSMB will halt the trial early because of excess deaths. Now, the point I'm making is if you have 22,000 physician signatures on a petition saying MOC is not meaningful, maybe you don't need a lot more data. All right? Maybe you're not going to get high-quality data. Now, we talked about CME. The argument has been made that CME is too passive. Frankly, I think it's hard to imagine anything more passive than sitting at a computer clicking on MOC modules for 10 to 20 hours. That, to me, is pretty boring. We like CME. CME sometimes is maligned because physicians and administrators misinterpret it and think it's industry promoted. And it's not. It should be, we're talking about ACCME credentialed CME. And that's a pretty rigorous group now. And it wasn't always that way, but it is now. And you have to do a needs assessment, a gap analysis, a lot of conflict of interest issues, a lot of evaluations. It has to be independent of commercial interests. And one of the things I like about CME is that CME can include future innovations and keep the physician on the cutting edge, whereas MOC, if you're going to take a test, it really has to be on established knowledge base. CME offerings are very competitive. I design a very extensive CME conference, a 3-day conference every year, and boy, I sit down with a blank piece of paper and say, okay, if I was going to this conference, what would I like to learn about? And what is going to make me come back? And if I don't do a good conference, they're not going to come back. So that's important. I think competition is good. This contrasts with the virtual monopoly that ABM has on MOC. Now, the recertification exam. This is controversial. I guarantee you that there are some people in this exam, in this room, who think the recertification exam is important. I know there is. Whenever I present this, it's usually in medical executive committees, and you get usually 1 out of 10 that thinks it's really important that we have some kind of exam. All right, so if you think it's important, I want you to just listen to this and just have an open mind. Because at first I was kind of plus or minus on this, and I've been lobbied heavily, and I'm convinced now. Most importantly, the exam questions are often not relevant to the physician's practice. They often relate to parts of the specialty they don't practice. So I have anesthesiologists calling me and saying, I don't understand, I have to study about pediatric anesthesiology, and I don't ever treat kids. It doesn't make any sense. I think this is one of the reasons we have so much support against MOC from the academicians because academicians are generally highly specialized. And think about for a second the researcher, the basic scientist who has a clinic. He does 80% research, 20% clinic. One day a week they're in clinic. They don't want to spend 20 hours every year doing MOC. It doesn't make sense for them. The questions are often outdated. These the questions, I mean, I did my recertification. I have my fellows come back and they talk to me about the exam every year. And really you have to study for the test. You study for the test, not what's in the practice. So the test in interventional cardiology this year had a lot of 2B3 inhibitors on it. My fellows know them very well. We never use them anymore. That's how these tests are. You have to go to the course review so you know what's going to be on the test and know how to answer the question for the tester. Has nothing to do with practice. Testing, I don't want to say it has nothing to do with practice, but it's often not related to practice. It's a better way to say it. The testing guidelines often uses guidelines as gold standard, but guidelines change, they often reverse. And a lot of folks think that closed book tests are outdated completely since we have the internet when we work and we use our colleagues so much to take care of patients. And I want to make the point that there's no recertification programs or any of these exams outside of the United States. This is a US-based issue. Now, often you hear, don't pilots have to maintain currency? Don't you want the doctors to be have at least as rigorous recertification requirements as pilots? And I think I'm pretty well situated to answer that question because I am a licensed instrument and commercial pilot. These are some of the planes I fly. That's in the middle is my Facebook picture. So let me tell you what happens as pilots. Our flight reviews are required every 2 years. They involve at least 1 hour of ground training and 1 hour of flying by a certified instructor. Usually it's more than that. We select the instructor. The applicant selects the instructor. It's very practical. They have you close your eyes, put your head in your lap, and then they practically turn the plane upside down as though you fell asleep. And then you have to open your eyes and light the plane up again. It's kind of important. There are no written exams, no computer modules. You can't fail. You cannot fail. That's not the point. The point is to work with someone and make sure that you feel comfortable and he feels comfortable. It costs about $100 to $200, depending on the instructor you choose. The commercial requirement is more intense. It's a 1-week deal, but the same thing is practical. It's not exam-based. And it's definitely not a waste of time. We kind of like it. Now, if every 2 years a doctor who we selected and respected work side by side with us, and this, by the way, is not a bad idea. This would be kind of fun to do. If they work side by side with us for a day, we would love it. You can even have your competitor from across town come and work with you. I think that would be interesting. And you would not get kind of pushback on that. I think that would be somewhat valuable. Now, what about costs? Costs for the MOC, they begin at $190 per year. They go up to $256, depending on what your specialty is. Plus, you have to do module fees if you want to use other people's modules like the ACP. Costs do increase significantly. You have more than one board, as most of us do. On top of this, costs for the review courses, travel to review courses. If you're in practice, it takes time away from your practice. The practicing physicians are really upset about this. And that costs them a lot of money. So let's talk about money. Value is virtuous. So if you look at the ABM IRS Form 990, it tells the whole story. The annual revenue is $55 million, and that's per year. The directors are well paid. Now, in medicine, we've all had to recently tighten our belts. Patients, I don't find patients demanding MOC, but they are demanding better value, better care, lower cost. Recently, most physicians, like myself, have spent enormous amounts of time cutting costs in their practices, and for me, particularly in the hospital. Now we're asking the ABIN for a better value. I think you're going to have to cut your fees, and you're going to have to figure out a way to make it work, unless, like we're all doing in medicine. So here's a 990, and this is the proof. This is from 2012. I'm sure it's higher now. $55 million a year company. Now, this next slide shows the highest paid employees, and I wasn't even going to show this just out of politeness. I actually don't even care if people make a lot. I think I want all my friends to be rich. It's fine with me. And a lot's made of the CEOs making almost $1 million a year. But I looked at this again last week as I was preparing, and I was shocked by something I saw that I just sent a chill down my spine. It was these two guys, Dr. Holmbo and Dr. Lipman. And I said, I know those two. Well, why do I know them? Because I've been reading their papers. And I didn't know that I thought they were affiliated with ABIM. that they were consultants or something, making a few $1,000s a year. $452,000 a year? There's something wrong with this. I'm sorry. And these are the people writing the papers that then the ABIM and ABMS is using to justify this process? That's not right. That doesn't pass the smell test. Something's got to be done about that. And I'm really upset about it, and I wasn't going to show this, but I think it's just too glaring. And there are other conflicts of interest to be aware of. The ACP and the ACC. Now, I'm not saying they're corrupt organizations, but they do make money from selling MOC study and testing materials. So just be aware of that when you hear, ACP put out a message a few days ago criticizing essentially me, and just be aware of the potential conflict of interest there. So Dr. Barron has pointed out the apology that ABM now is under fire from many organizations. I think the apology was good. This is my personal apology. Dear Dr. Teirstein, you got it wrong. And I appreciate that, and I think it was a good first step. Part 4 is suspended. I think that's a very good decision. But the other changes really aren't meaningful. They're changing their public reporting language of diplomatic status. That's okay. That's really hardly the main issue. Freezing the already exorbitant fees, okay? I mean, we can maybe retract the fees. And then there were promises to consider further changes, but they weren't made. We still left with parts 2 and 3, which are the onerous, this is the self-exam, self-assessment modules and the repeat secure testing of tenures. These are onerous and they're time-wasting and they're expensive. The self-admitted poor rollout of MOC by ABIM illustrates the need for an alternative certifying organization or organizations. It might interest you to know that after this apology, applications for board certification by the alternative NBPAS board tripled, with a lot of scathing comments. Like that is just hardly enough. You can read them, you can see them on our website. So what is the NBPAS? It doesn't replace ABMS at all. It supports the initial ABMS certification criteria, which is completion of an ACGME accredited program and a secure test. It strongly objects to current MOC requirements. It supports physician choice. Physicians who believe they benefit from MOC should participate. Lifelong learning is not a one-size-fits-all. And NBPAS provides physicians with an important alternative, and these are the criteria. These are the criteria that we use, and they're very similar. Licensure, we substitute CME for all of the modules and secure tests, and we have some requirements that are more stringent than ABIM. If you ever were kicked out of off your hospital, if you lost your privileges and if they were revoked and not reinstated, then we don't want to certify you. The board members are well-respected, high-profile members of the academic medical community. You can see them here. They come from Mayo Clinic, Harvard, Columbia, UMass. It's a simple website. It contains some data, some interesting data, the perspectives of both sides. You can find them there. You can find the apology. You can find the NBPAS reaction to the apology. Some screenshots. It's very easy to, it takes about 15 minutes to use this. And by the way, you might be interested to know that we have to verify all the information the physicians give us. So to do that, we actually have to pay the ABMS. Because a patient can find out if a doctor's certified, but if you're a professional organization, like all of your hospitals, you have to pay to find out whether or not doctors are certified. This is a not-for-profit organization. The fee is about $85 a year. It may go down. If we don't need to charge as much, we'll lower it. Physician management is not being paid. And I encourage you to go to the website and check it out. So I'll conclude, and I think there is a need for an alternative. Irrespective of how this issue is resolved, the process of evaluating MOC has shed enormous light on how medicine is regulated in the United States. In the past, ABMS, ABIM has made contributions to patient care, but it is also clear that the ABIM is a private, self-appointed credentialing organization. ABM has grown into a big $55 million or more business, unfettered by competition, with economic goals, selling proprietary copyrighted products. It's time for other organizations to compete with ABIM and offer alternative credentialing options. And I'll just finalize with my fantasy headline: breaking news, physicians finally extract heads from sand. Docs came close to ceding control of the entire profession. I'm getting a lot of feedback from doctors saying you know, it's about time we really stood up for ourselves. This has been a sentinel event for many physicians, especially myself, waking up to the fact that our profession is controlled by individuals who are not involved with the day-to-day care of patients. And when confronted with the inequities of MOC, many initially reacted with jaded pessimism, saying it's too late, MOC is here to stay, the horse is out of the barn. But ABM is making changes and alternatives have appeared. We can't put the horse back in the barn. It's time for practicing physicians to take back the leadership of medicine. Thank you.